Okay, well, good morning, everyone. Welcome to either, depending on whether you're an intern or senior, either the first or the last ground rounds of the academic year. Um, and some cheers from the back row there. Okay, so it's my pleasure this morning to introduce our speaker, Dr. Kate Perry, who's the chief of our Division of Nephrology here at Phoenix Children's. She's been in practice for more than 20 years and is a very accomplished medical educator as well as researcher, in addition to clinician. She did her training in pediatrics at the Children's Hospital, Los Angeles, followed by fellowships in nephrology and medical education at UCLA, where she stayed as faculty until 2022, before moving here to Phoenix to become our division chief in nephrology. She served as a principal investigator on numerous projects funded by the NIH and other leading research organizations. Her research primarily focuses on the effects of uremia and small molecules on bone cell health and growth. And she's had more than 70 peer-reviewed papers to her credit. From the earliest days of her career, Dr. Perry has participated in professional societies to advance her expertise and continues active membership in organizations, including the Society of Pediatric Research, the American Society for Bone and Mineral Research, and the American Society of Pediatric Nephrology. She's a long record of service and leadership with the American Society of Nephrology's Kidney Stars program and the National Kidney Foundation, amongst other groups. And before we advance to her cover slide, I just want everybody here to test out, see if you can get this QR code to work. And maybe Dr. Perry will need you to go over, you can come over to the podium. We're going to implement, starting with the new year, a simplified evaluation system for grand round. So basically you have one number to click, 0 to 10, and then you can put in an optional comment. So we're hoping that this is like the least painless evaluation possible. But it will get us some feedback that we can give our speakers. A lot of times want to know, what did you guys get out of it? So if everybody's got their QR code in that, I'm going to then get this all set up and we'll let Dr. Perry take it away.
It's all going. Okay, good morning, everybody. And thank you for that welcome and introduction. And while I will admit that my main research interest has been the bone disease associated with kidney failure, one of the things I love most is renal physiology. And I've realized in my time as a nephrologist that not everybody loves it quite as much as I do. These wonderful people, the reason I went into pediatrics, the people, the kids, but not everyone has a bent towards physiology. And it's constantly a painful thing to me. And it's been a little bit of my mission over the years to see how I can sort of demystify, maybe the wrong word, but sort of simplify it so that all these wonderful people that I think are fantastic physicians don't panic when they see numbers and multiple choice on a board exam. This is not something you're going to lose points over. This should be I got this. This is a limited differential and I can do this. And so that is my goal today, is to talk a little bit about metabolic alkalosis. Now, I was at UCLA for many years and the grand rounds were on Friday mornings. And so when I was rounding, and I was always a little bit tired by Friday, I would always tell the residents, oh, I'm not teaching on Friday, but if we have to teach about metabolic alkalosis, because for me, it's tidy and quick and we can wrap our brains around this one. So let's see if we can do this today. And I'm also, if you want to just raise your hands and ask questions, if things are not clear along the way, absolutely. Please do that. Okay, so we're going to start with a case, because for those of you who are going to be taking board exams, every board exam I ever took, I think it has this child on it. and there it is, a clinical presentation that can have a lot of different causes of metabolic alkalosis associated with it. And what the examiner is asking you is, do you really know how to parse this out? And can you get to the answer pretty quickly? And I'll walk you through that so that a question like this doesn't appear hard if it does initially. So the case would be a 5 or a 6-week-old child, often a boy, admitted to the emergency room with failure to thrive and dehydration. And what the question wants to know is, whatever, you can pick your strange associated feature and we'll go through them all, but they want to know, A, do you know like what can cause these abnormalities in the labs, and then what they're associated with, right? One step down. So what's going through the head of many people when they see this is, what in the world does this kid have? The bicarb's high, the potassium's low, there's something wrong with sodium. This is not good. Should I call the nephrologist? Yeah, probably, right? Because it's weird numbers here. Or maybe I should call the PICU attending because I don't know, they're all kind of abnormal. Or maybe I should just stand here and panic and, oh, well, I'm taking a test now. Are those my labs? Because, right, hyperventilating could do something to them. Shouldn't I just skip over this one and go on to the development questions about Cheerios and when kids can pick them up? But then, you know, is that my kid? When my kid could do that, or the regular kid, or the advanced kid? That's so bad. I'm giving you some insights into my train of thought because the developmental questions, I was always like, Anyway, so the objectives of this talk are to understand the roles that the stomach and kidney play in metabolic acid and base balance, and to be able to differentiate renal from extra-renal causes of a metabolic alkalosis. Because that high bicarb there, that's what we're going for. This was a metabolic alkalosis, and I'll get to how we make that diagnosis in just a minute. I also want you guys to all understand the role of salt absorption and acid excretion in the development of metabolic alkalosis, and to be able to address board-style acid-based questions quickly, easily, and correctly. Okay, back to medical school. There won't be too much of this medical school-like stuff that throws everybody into a panic. But I just want to remind everybody of how our body and how biology in general deals with mopping up extra acid and handling that acid load every day that we all have from just metabolism, just using energy, breaking down proteins, right? We all generate a huge amount of acid every day. It's the bicarbonate buffering system, which will take, right? It'll take protons. That's the H here. I use this. That's the H plus, right? That's a proton. That's acid. And this is the bicarbonate that we're measuring, that total CO2 you see on the labs. Most of it is this bicarbonate. This is the base. This is our acid. Those two join together to form H2CO3, and that can break down to carbon dioxide and water. But all of this does not occur in this like linear fashion, right? In a test tube, this is happening in the body, and it's actually happening all in one place in the presence of an enzyme that does this all together, right? This is all the proton and the bicarbonate enter this enzyme, and out come carbon dioxide and water, simplified. Okay, normal values, to remind everybody, for your blood pH, okay, 7.4. If it's lower than that, we're talking about acidosis. If it's higher than that, we're talking about alkalosis. Okay, and this is the important thing to remember. It's the pH that determines whether you're alkalotic or acidemic, and not the bicarbonate itself. Okay, the normal concentration of PCO2 in the blood should be 40. Okay, if higher, your lungs are retaining carbon dioxide, and if it's lower, your lungs are blowing off carbon dioxide. Because not only, I think I'm pretty kidney centric, not only is the kidney managing acid base, but the lungs are also. So this is by excreting from the lungs, by breathing off, we are also able to get rid of this acid load, right? Normal bicarbonate is 24. Higher or lower can be acidosis or alkalosis, but it depends on what the pH is. Okay. Okay, so this is just to show you what a picture of that carbonic anhydrase, that big enzyme is that takes proton and bicarbonate and turns it into water and carbon dioxide, or the reverse process also, right? There's a little cleft in here. So though that all happens here all together in one location. When I put up this example for residents when we're on rounds, and it has happened every time I've done it for the past 20 years at every place I've given this talk. When I put up a little example of a high bicarbonate or of the other example of a low bicarbonate, and I ask residents what the acid-base diagnosis is, I get a lot of panic and then little bit of overthinking. I get maybe it's a metabolic alkalosis, but maybe it's a compensation. Okay, I want to show you something here to simplify things a little bit for you. If we have an acidosis, so that's a pH thing, right? If their pH in the blood is less than 7.4, that's acidosis, right? And the bicarbonate is low, that comes from the kidneys doing that. But look what happens. What's the physiologic response? It blows your lungs blow your PCO2 down because you're acidemic, right? Think about this for a second. If we think back to the equation we saw on the previous slide, if you lower the CO2, what's that going to do to the bicarb? It's going to push it down even further. So when you want to think about these problems, think about what you think is going on, the primary problem. The compensation is going to blow, you're going to push your bicarbonate in the same direction as the insult. Hope that makes sense to you. Take a minute to let that sink in. If you have a metabolic acidosis, you're going to push your bicarb down. Okay, the response is your lungs are going to push the CO2 down. That is going to drive your bicarbonate further down. Now, the compensation drives the pH in opposite directions. Hopefully you get more towards 7.4. That's the goal, is to normalize the pH. It's not to normalize the bicarbonate. So when someone shows you a set of labs and the bicarbonate's out of whack, you can just think of the primary process and what you really want to get out at for there. If you really want to go through all the formulas, and that's the point of the exercise, to get really deeply into it, great. Then you can think about compensation because these formulas are valid. If you're really trying to take care of a patient or be very quick on a test, just try to think what the initiating event would be, because the bicarbonate will go even further in the same direction from the response. Okay? So summary of that is the primary process and the compensation always drive the bicarbonate in the same direction. If you can identify the primary process, do it and move on. And how do you identify it? Look at your pH, the blood pH. All right. Okay, so we've got a low bicarbonate. This can either be a metabolic acidosis. Okay, so the kidney is somehow not getting rid of protons and it's sopping up your bicarbonate, okay, making it drop. Or a respiratory alkalosis. The lungs are blowing off too much CO2. All right. Either one of those can do it. And the response for metabolic acidosis is a respiratory alkalosis. And the response for respiratory alkalosis is a metabolic acidosis. You don't know which it is until you look at the blood pH. Okay. If it's less than 7.4, that's an acidosis. And it's metabolic. If it's greater than 7.4, that's an alkalosis. And it's coming from the lungs. Same thing with a high bicarbonate. If it's high, it's either metabolic alkalosis, respiratory acidosis. The compensation is going to drive the bicarb in the same direction. Okay, let's get back to our case. We have this 5-week-old child in the ER, failure to thrive in dehydration, and you see a low sodium, lowish sodium, a low potassium, and a high bicarbonate. I'm also going to point out something to you here that's going to come back. We're going to see this. Look at that chloride. That's kind of low too, right? Okay. So you see here that we got a blood pH on this child and it's 7.5. So this is above 7.4. This is alkalemia. All right. Okay. So we've made our acid-base diagnosis. This is an alkalemia. And because the bicarbonate is high, this is metabolic. This is a metabolic alkalosis. What organs can cause this? Now we're getting to the differential part, right? Okay. So we want to think about the organs that do the metabolic part of acid base. Okay, so the lungs breathe off CO2. I'm not talking about that part. I'm talking about the organs that will split, your H2CO3 into a proton and bicarbonate. And you've got two of them, really. The stomach, okay, and the intestines can do it too. And then we're going to talk about the kidney. So these are the two main ones that we're going to talk about when it comes to metabolic alkalosis, the stomach and the kidney, and a little bit also the skin. We'll get there in a second. Okay, so remember when you are making stomach acid, this is how you digest your food, right? You are putting protons into the stomach and making your stomach acid. You're dropping the pH real low when you do that, right? Okay, how do you generate those protons? You do it the same way that you are making bicarbonate in the kidney. Okay, you're taking H2CO3 and you're splitting it in the presence of carbonic anhydride into a proton, which gets pumped into the stomach lumen, and a bicarbonate, which you are putting back into the bloodstream, essentially, okay, in exchange for chloride. Okay, so think about what happens if you lose all of this acid that you're putting into the stomach. And how would you do that? You do it by throwing it, right? Great. Okay, where else could you get an alkalosis? You filter a huge amount of bicarbonate every day at the level of the glomerulus. Remember this thing here? It is freely filtered right across with everything. Theoretically, you're going to reabsorb the vast majority of it in the proximal tubule, a little bit of it in the thick ascending limb. So the tubules of the kidney do a great job in resorbing this bicarbonate as they should. Okay. And later on in the nephron, you are putting acid into your urine, okay, in the form of protons, okay? And so later on in the nephron, you are revving up this carbonic anhydrase, putting protons into the urine and reabsorbing bicarbonate in exchange for chloride, okay? So this system here is really in the distal tubule is where we can really generate an alkalosis and keep it maintained. Okay, I want to show you something. We don't have to get into every single little cell here in the distal tubule, but I want to just point something out to you. There is a specialized cell, if you remember way back to medical school, that allows you to get rid of extra bicarb in the urine. But in order to do that, you have to be able to reabsorb some chloride. If there is no chloride around, you won't be able to get rid of that extra bicarbonate. Why might there not be chloride coming out in your urine? If you're really dehydrated. Okay, so in order for you to get rid of extra bicarbonate, like your body might want to do, you really can't be volume depleted. You have to have chloride around to do that. So that's very important when it comes to thinking about how an alkalosis gets maintained. If you're forcing the kid to be dehydrated, they will stay alkalotic. Okay, is there another organ? Think about chloride. Yes, there is another organ that can help us generate an alkalosis. Right? The chloride in this child with a high bicarbonate is low. It's always low in these kids with metabolic alkalosis. Okay. If you can flip your mind to thinking about how a kid gets alkalotic, not by acid base, but where chloride is lost, you can really kind of turn the temperature down on your thinking and just be a lot cooler and calmer. Okay, if you're losing a huge amount of chloride, you can think a little bit simply. If the body is volume depleted, it wants to reabsorb sodium, and if there's no chloride around, it will reabsorb bicarb. Okay, so think about that low chloride. Where are we losing chloride? Well, if you're vomiting in the stomach, that's a proton plus chloride, right? Okay, where else do you lose chloride? Okay, that's the stomach. We talked about that one. Think about the skin also. Okay, if you have massive sweating, right? You're losing massive amounts of chloride. It's really interesting that there's a bicarbonate sort of resorption mechanism here as well. And it and if you think about children with defects in CFTR, who are those children? Children with CF, they have very salty skin. Okay, they have defects in that chloride transporter. There is a poor crosstalk with bicarbonate. Bicarbonate should be feeding back, and it doesn't in those children. So they have a lot of chloride losses. Those children will also become alkalotic. Okay. All right. So I think we talked about this already. It's important to remember that sodium chloride reabsorption is linked to acid excretion. If you don't have any volume going by in the last part of the tubule, you can't get rid of extra acid. Okay, you also can't get rid of extra base. So once you've got your problem, if you're dehydrated, you're gonna keep it there until you can restore volume and get rid of that extra, in this case, bicarbonate. Okay. So part of this is due to aldosterone. All right, think about that hormone that's made in the adrenals that responds to low volume, right? What does it do? It talks to the distal part of the kidney, makes you excrete potassium into the urine. Okay, it also makes you excrete protons into the urine. Okay, and if you're excreting protons into the urine, you think about if you split a proton, the other part is resorbing a bicarbonate. Okay, so if you have a lot of aldo around, you're gonna get an alkalosis from that. How would you do that? Well, if you have something where you're losing salt, this part of the kidney maybe, aldosterone works here. Okay, if you lose a lot of salt here, and the body says, whoa, I'm volume depleted. Okay, I need to get all my mechanisms going to resorb more salt, and that includes aldosterone. Okay, aldosterone isn't going to talk here and slow down that salt loss here in the thick ascending limb. It is going to talk to the distal part of the nephron and say, okay, I'm going to reabsorb salt here. Okay, and when it does that, it makes you lose potassium and protons, both of those. What sorts of things force you to lose salt here? This is a loop, right? This is the loop of Henle. The medicines are named after this loop, the loop diuretics. And there's also a syndrome you'll see in kids called Bartter syndrome that is a defect here. Okay. So you think about thick ascending loop pathology. Some pathologies right here can do it too. This is a distal convoluted tubule. Gittleman syndrome affects here. So it's just those two things, Bartter syndrome and Gittleman syndrome, or Lasix use, that can make you lose salt, and then you see the effects of aldosterone. Okay.
What is PAO disorders?
Thick ascending limb. Thank you for asking me. I shouldn't use those abbreviations. Thick ascending limb of the loop of Henle. Yeah. Do you want to be a nephrologist? We'll train you in all. Just kidding. Always recruiting. So hypovolemia from sodium chloride loss leads to high aldosterone levels. That talks to the distal tubule and makes you put acid in the urine. It causes a metabolic alkalosis. Okay. And we already talked about if you don't have chloride here going by this part of the nephron, if you have an alkalosis already, you can't correct it. There is nothing to reabsorb in exchange for the bicarbonate. So having low chloride will make you maintain that alkalosis. Okay, let's get back to our case. We have a 5-week-old child admitted in the ER, failure to thrive in dehydration. We've determined this child is alkalotic. It's a metabolic alkalosis because the bicarb is high. So where are we losing our chloride? All right, because that's how we're going to be thinking about metabolic alkalosis. Where are we losing chloride? Are we losing it in the kidney, in that thick ascending limb part of the kidney? Or are we losing it somewhere else, becoming volume depleted, and we have a lot of aldosterone around? How do we figure that out? Okay, think about what the kidney should be doing. All right, if you're volume depleted, okay, and you have a lot of aldosterone around as an effect, and that's causing your alkalosis, what should you see in the urine? Your kidney should be holding on to every drop of chloride it possibly can. Okay, so you can use that fact to your advantage. If you check just the urine chloride, and you don't have to normalize it by anything, just the urine chloride concentration, and you find out it's real low, and the number here is 15. So some sources say 15 MEQs per liter, some say 20 MEQs per liter, low. If it's real low, that says to you, the kidney is smart and doing what it's supposed to do. There's no problem. Okay, it is holding on to every drop of chloride. So my losses of chloride must be somewhere else, extrarenal. Okay, we're going to divide all this by renal and extrarenal. Where else could that be? We talked about the stomach, HCl, vomiting, right? And we talked about the skin, all right, sweating, extra sweating. What 5-week-old boy has projectile vomiting? The little boy with an olive, okay, who has pyloric stenosis. So what's the weird factoid you're going to remember with the pyloric stenosis? You're going to remember the olive. You're also going to remember how old this kid is. Okay, just an infant, a couple months old. Okay, cystic fibrosis, right? That's the other one. Remember, that's an autosomal recessive. They have high sweat chloride. The child maybe tastes salty when the parent kisses them. They have recurrent pulmonary sinus infections, greasy stools, malabsorption. Why am I listing all of these? Because your question is, what weird thing is associated with these lab values, right? Okay, if in your little scenario, they say you got these lab values and oh, by the way, the mom kisses him and he's salty. This is the child with cystic fibrosis, right? Right, okay. So on the other hand, if you check a urinary chloride and this child with chloride is low, maybe the exam will be a little more sophisticated than I am, but usually they're not. So if you have a high urinary chloride and greater than 15 to 20, but oftentimes it's way high, like greater than 75 MEQs per liter, and the child is hypochloremic and has a metabolic alkalosis, that ain't right. The kidney is not doing its job. Okay, that's a renal cause of the metabolic alkalosis. And if your blood pressure goes up a little bit with that, okay, all right, but it's a very limited number of things it can do. Just keep yourself calm with that, okay? As long as the kid has normal blood pressure and is not high blood pressure, okay? We'll get to the high blood pressure example at the end here. It's also just one thing, okay? This has to be the loop of Henle, the thick ascending limb of the loop of Henle, or DCT is distal convoluted tubule. Thank you. Or the distal convoluted tubule. It has to be that part of the nephron before you get to the collecting duct where aldosterone works. Okay, what works there? Loop diuretics can paralyze that thick ascending limb, okay, and cause a lot of salt to come out in the urine. And then you have to have a lot of aldosterone to resorb as much sodium as you can in the cortical collecting duct, and with it, you're absorbing bicarbonate and not chloride. Okay, Bartter syndrome is a genetic defect in the same transporter that the loop diuretics affect, or there are 5 types of Bartter syndrome that affect 5 different transporters. However, the process by which salt is absorbed is the same one that loop diuretics all affect. So you can remember Bartter syndrome, same labs as a kid on Lasix, okay? But they might have these associated features. This child might have had polyhydramnios in utero. They will have hypercalciuria when they're born, and they might have some associated hearing loss. Okay. There is a syndrome called Gittleman syndrome, which has similar labs. It's not quite as severe as Bartter syndrome. This also causes sodium chloride loss. They also have low serum magnesium, these kids with Gittleman syndrome. And actually, this is usually diagnosed later and in later childhood or adulthood, Gittleman syndrome is, or Bartter syndrome is more commonly identified early on in infancy. This affects a transporter in the distal convoluted tubule, so just past the thick ascending limb. but not yet to the cortical chloride. Okay, the one exception for this thick ascending limb pathology is if you have too much aldosterone, and that's just the primary problem. Okay, those kids will have hypertension, and they're the only ones that will. Okay, so there are some things that so if you just remember aldosterone excess, you'll be good. There are some nephrology things that nephrologists loves that are very rare that will not be on your general peds boards. So Little syndrome and congenital adrenal hyperplasia and these things. But if you can remember aldosterone excess for the kid who is hypertensive, this will be the only kid who's hypertensive with alkalosis. Okay. Okay, we're getting back to our example. We're gonna get there, and it's not gonna take you this long on your boards once we get there. All right, so we've got our alkalotic child with low chloride and a high bicarb, and we get a urinary chloride because the boards will give you this if they're wanting you to figure out what this kid has. The urinary chloride is 75, real high. Okay, so we know now that a high urinary chloride means the kidney is not doing the job it's supposed to do in resorbing every single bit of chloride that it should. Okay, so we have to switch and think now we're just focusing on the things that the kidney can do, and that will be Bartter syndrome or Gittleman syndrome, or it'll be Lasix, and then we're done. So, but we're not given that example. You look at it and you're like, shoot, I know the answer, but now I've got these weird things here. Okay, we're going to slow down for a minute and we're going to say palpable olive pneumonia, sensory neural deafness, or Pickwickian syndrome. What are those associated with? I knew it was Bartter syndrome. Why are they asking me this stuff? Okay. You have to think one more little step here. Okay, I knew it was Bartter syndrome. That I know can be associated with deafness and polyuria. Okay. Cystic fibrosis is the one associated with pneumonia. I'm not going to pick that one because the urinary chloride would be low in that one. Pyloric stenosis, that's associated with an olive. That's not what they're giving me, right? Okay, so pyloric stenosis, urinary chloride should be low in that one. If this is Pickwickian syndrome, the increased respiratory rate, what would that do? That would give me an alkalosis, that's for sure, right? The pH would be high, but that would be a respiratory alkalosis. And so my CO2 would be low. So the labs don't even fit that one. So Bartter syndrome, I knew it had to be either Bartter syndrome or Lasix use, and here's the only one. And deafness polyuria is the thing I'm going to pick here. Okay, so that's how I work through them. You'll get faster at this as you do them. So we're going to have a second example. Same kid, blood pressure low, high blood pH. So this is alkalosis again, right? Okay. High bicarbonate, but remember, we're not going to think about bicarbonate as much as we're going to think about where we're losing chloride, because that chloride is wicked low, right? Now here, urinary chloride is 5. Kidney smart or dumb? They're smart. All right, forget the kidney stuff now. Where outside the kidneys can we be losing chloride? Stomach, skin. Oh, but we've got the features, polyhydramnios, salty skin, mag. This is sensory neural deafness. Okay, I go through the same thing. I say, this is either CF or vomiting, right? And then I say, okay, CF, that's the salty skin, right? So I'm going to pick B for that one. All right. So they make you think 2 steps down the road, but you can do it. So once you got CF, you pick your associated feature. What would the hypomagnesemia be? That's Gittleman. The urinary chloride would be high. Polyhydramnios, that's not spelled correctly, but anyway, that would be Bartter syndrome. Urinary chloride really high. Okay, sensory neural deafness. Okay, that would be Bartter's. Or too much Lasix could do it too. All right, urinary chloride would be too high. So the only one would fit would be the salty skin. All right. Example 3, here's our important exception. We've got a 16-year-old boy comes to the ER, weakness and dehydration, and he's got a metabolic alkalosis and his potassium's low and his blood pressure is 140/30 and the urinary chloride is 75, you say, aha, I got it. He's taking too much Lasix, or he's got Bartter syndrome at 16, just coming to diagnosis. But what about that blood pressure? That's your one thing. Remember, that blood pressure is high. Ding, ding, ding. This is your exception. This is something with aldosterone, and you're going to pick the adrenal nodule here. Okay. Okay. Primary aldosterone excess or something that mimics it. And so if you like these sort of thing, Nephrology Fellowship is the way to go. And we are here to help you with that. All right. So some just other little factoids. That is what those are the examples, and that is what you will have when it comes to test taking and the vast majority of times on the wards. And most of the metabolic alkalosis you'll see is dehydration from loop diuretics. But in this hospital, you will see the wild and wacky and wonderful things too. And so you'll see them all. But some other factoids to remember, a low potassium almost always co-occurs with a metabolic alkalosis. Why is this? Because the response to the low volume from all that chloride loss is high aldo, and aldo makes you excrete potassium. Okay, so you're always going to see that low potassium along with the metabolic alkalosis. The other interesting thing is that low potassium actually sort of fuels proton excretion. So it fuels acid excretion. And it does that by ramping up your ability to make ammonia in the kidney. It's the primary it's a very potent stimulus for ammonia production. Just a little factoid there. So ammonia is produced in the proximal tubule, and it's what causes us to be able to excrete so much acid every day. You don't excrete it as free protons, it's ammonia. And if you have a low potassium, you generate a lot of this, and you can excrete a lot of hydrogen in the distal tubule, and so that'll potentiate your alkalosis. You don't have to remember that, but it's just fun and interesting. Another interesting factoid is hypercalcemia can also lead to a metabolic alkalosis. So just think about where a lot of calcium is reabsorbed in the kidney. And if you remember your physiology, a lot of this is reabsorbed in the thick ascending limb, and it's reabsorbed as you're reabsorbing sodium chloride there, right? So if you have hypercalcemia, what do? You give a lot of saline and you give Lasix, because Lasix will inhibit your sodium chloride reabsorption right there in the thick ascending limb. And when you do that, you cannot reabsorb as much calcium. Calcium gets dragged across as you're reabsorbing salt right there. Okay. But if you have hypercalcemia just to start with, it's going to drag everything along and not allow salt to be reabsorbed. And then you're going to get that aldosterone response later on. Okay. So just a couple of fun factoids. In summary, to beat a dead horse over again, our alkalosis workup is you want to determine whether the alkalosis is chloride sensitive or responsive. How would you do that? This is another fancy way. You'll hear this sometimes. Don't let anybody throw you. This just means, is the kidney excreting chloride, which means it's dumb, okay? And giving more chloride isn't going to fix it. That is not responsive. That is a kidney problem. Or is the kidney reabsorbing all the chloride? And then that would respond to chloride. You're losing chloride somewhere else. And if you gave IV saline infusion, you'd fix that problem, right? Okay. If you have chloride resistant, that's a high urinary chloride, then all you have to do is see, is the blood pressure high or is it low? Okay. And if it's high, that's aldo. And if it's low or normal, that's your Lasix or your Bartter syndrome. Okay, so if your urine chloride is low, you remember, you're going to think cystic fibrosis, pyloric stenosis, and I threw in this fun one that they only see in adults, chloride diarrhea. Or if the urine chloride is very, very high and the kidney is dumb, you have loop diuretics, Bartter syndrome, or Gittleman syndrome, unless you have hypertension. Okay, summary. So this child has what strange associated feature? Your initial response might be, But then you're gonna calm down and say, okay, I got this. Should you call the nephrologist that PICU attending? Well, maybe. Maybe you should, but not from the numbers necessarily. Well, the nephrologist maybe for the numbers. The PICU attending, if the kid is looking really bad, right? Or should I stand here and panic? No, you're not gonna panic. Okay, the other two questions, maybe. Oh, I'm taking a test. Are those my labs? Am I hyperventilating? Should I just skip this question, go on to something else that I know the answer to? No. You're gonna be able to answer this one. It's a limited differential, okay? And there's only gonna be one right answer, really. And it's gonna, once you know to look at urinary chloride and determine whether it's coming from the kidney or not, it's gonna stick out like a sore thumb. So you're gonna calm down and you're gonna pick the right one, and then you're gonna go on to the others that are easy, and then you're gonna come back to the Cheerio questions. Because those are hard. Vasu's laughing at me. She doesn't think they're as hard, but for me. So that's all I had today. I want to know if any of you have any questions. Or if anybody wants to be a nephrologist, because we're always recruiting.
Do you have a nephrology fellowship here or?
We
are you
do.
Thinking of it as.
We do. And we are recruiting. We have one. It's been approved.
Okay.
So we could have someone starting this fall. We don't have any candidates. It was just approved after the match last year, somewhere in late fall. Yeah. We have our eye on someone in your residency, but I don't call her out for fear I frighten her off, you know.
Well, I'm gonna start next July, that July 2025 academic year, but you're open to internal candidates.
Yeah.
Very-
One of the other things I always like to point out when talking about looking at lab values for board exams is that we often learn these in terms of, like if I ask you about Pylorus stenosis, you are going to tell me it's a hyperchloremic metabolic fibrosis. That's how you memorized it. And so when I see these labs, I actually write down what I see, not low chloride, I actually write hypochloremic or hyponatremic, because those are the ways that we tend to like make our pattern recognition, and we don't make our pattern recognition like low sodium, low potassium, high pH, or that's not usually the way. So that's one way to help you remember that, or to get through some of these that are a little more. Get over your panic.
Thank you. Does that help people? Yeah? Oh, okay, great. Yeah, I don't think that way, but then I know that my brain a little different, like I don't like to memorize stuff, so like that's my issue, but you know, yeah. No, you're not. You can memorize lots of stuff. It's fantastic. Yeah.
Just for residents in your careers, these are great labs for cholexinosis, but anything that causes a lot of vomiting will do that. There's been a few patients over the years that come in with this pyloric stenosis looking labs. And the history, and the history is that they're vomiting, but it's like, you have to vomit a lot to really lose that much thing. But it's a key thing to narrow in on what's a differential diagnosis going to be for an older patient. Because if you see those labs and they got a metabolic acidosis and a low chloride, it's like, okay, this patient's been vomiting a lot. Like 95% of patients who say they vomit a lot, but they have not.
Yeah. Other questions? All right. Okay. Well, thank you then.